Everyone, welcome to the webinar Elimination Initiative, Intensified Actions for Congenital Syphilis Elimination for the Caribbean. Welcome, welcome, welcome. We know that in the region of the Americas that it is facing right now an incidence rate for syphilis and congenital syphilis with reports of increases in cases among key population, pregnant women and newborns. Pan American Health Organization calculated and reported that between 2016 to 2022, the number of cases of congenital syphilis in the America rose by 40%, reaching a peak of more than 35,000 cases in 2022. 19 countries out of the 26 reporting countries observed increases in the prevalence of syphilis among pregnant women between 2015 and 2022. This is the reason because we are having today a webinar with the objective of reviewing outputs for the project, the regional project, outlining integration in the strategy, detailing and analyzing the barriers to impact implementation sustainable MTCT syphilis in the Caribbean. We engage dialogue between the different partners, present strategies, important strategies, to test and approach a new approach for syphilis among pregnant women to reduce the congenital syphilis and advocate to expand access for screening and innovative approach. Please be with us today, welcoming all the people that are in our webinar. And I invite Mr. Manoj Kumar. He's a politician counselor for the Indian High Commission in Guyana. Please, Manoj, the floor is yours.
Good morning to all of you. I am Manoj Kumar, Counselor Political in the Indian High Commission in Georgetown. I am here because the High Commission of India in Georgetown is accredited to CARICOM for India. So it is my pleasure to be part of this virtual launch of this multi-country aid project. Government of India is funding this project to eliminate these diseases by 2030. The project will be implemented in 15 countries by PAHO, the implementing agency, and Government of India is providing $1 million for this project. India United Nations Development Partnership Fund was established in 2017 with a view to support projects in developing countries that aim to contribute to achieving the Sustainable Development Goals. The fund adheres to the principles of South-South cooperation and places a priority on national ownership and leadership, equality, sustainability, development of local capacity, and mutual benefit. The fund particularly welcomes proposals from least developed countries, landlocked developing countries, and small island developing countries, SIDS, and supports projects that are in alignment with the 2030 agenda. A total of 100 million US dollar over the next decade has been committed by Government of India for the fund. Subsequently, in 2018 also, we had committed another 50 million US dollars from the Commonwealth window, and this project is being funded from that Commonwealth window. So till now, this fund has supported almost 85 projects in 65 countries spread over various geographical zones such as Pacific SIDS, Asia, Africa, and of course the Caribbean. while 50 projects in 34 countries have already been completed, and rest are at the various stages of implementation. I understand that the agreement for implementation of this project has already been signed, and today's ceremony launch marks the start of this project. And I take this opportunity to congratulate all stakeholders which took the lead, which made efforts, and especially the uh, bellies who took the lead in this project. And I also impress upon the implementing agency to complete the project in timely manner. With this, I end, and thank you very much for inviting me to the launch ceremony of this project. Thank you very much.
Thank you very much, Mr. Manoj Kumar. I'm sorry I didn't introduce myself. I am Rodolfo Gomez Ponce de Leon, the Regional Sexual and Reproductive Health Advisor for the Pan American Health Organization based in Washington, D.C., and I will be your moderator today. The next speaker for the welcome remarks is Ines Tofalo, Trust Fund and Project Management Specialist from UNOSSC. Please go ahead. The floor is yours, Ines.
Thank you very much. Good morning, everyone. It's really an honor and a pleasure to join you here today for what promises to be a very exciting project that is most important. I work at the UN Office for South-South Cooperation. For those who don't know us, we have a global and UN-wide system mandate promoting, advocating, and advancing cooperation among developing countries. We do that through a range of interventions. One is supporting member states of the United Nations system as they formulate policy to enable countries to cooperate with each other. We also support the UN system in its capacities to service member states and enable them to cooperate better among developing countries. We have several knowledge platforms, which I do encourage you to check in the context of implementing this project, as well as in your lines of work, including South-South Galaxy, which is an online platform to facilitate transfer of knowledge to enable South-South cooperation. We work a lot with think tanks, enabling networks of think tanks to act collaboratively, as well as several publications and other lines of knowledge products that might be of relevance to your respective lines of work. A third pillar of our work is trust fund management, and that is where this project comes in. We manage 4 trust funds, mostly supported by middle-income countries, cooperating with small island developing states and least developed countries. India being a major partner of the UN office, and the India UN Fund being the largest fund that UNOSSC is managing. We do all of this because we really firmly believe that there's nothing more catalytic to addressing things like mother-to-child transmission of infectious diseases than to take a collective approach. And regional and sub-regional approaches are most instrumental in South-South cooperation. Of course, diseases don't have passports, do not respect national boundaries. So if you want to eradicate these kinds of transmissions, you need to take a concerted approach. And therefore, I commend PAHO and the Caribbean countries for coming together with this resolution to do this as stated in this project. And we really wish you a lot of success in this short timeline to accomplish your objectives. I also think it's most inspirational that the partner supporting this initiative is not a rich country that has done this decades ago, but is India, a country that has shown really great leadership in South-South cooperation in health. It is a country that currently and in recent years has shown much promise in the introduction of new technologies, digitalization of its health systems, and radically transforming its health outcomes. It is also a country that has acted with superb solidarity at the time of COVID-19 in terms of vaccines. And I think that that's really something that we should stress. The India UN Fund, Mr. Kumar has already well described the parameters of this fund, but One thing that I think is important to stress is almost 1/3 of the portfolio, over $20 million of implemented resources, have gone to SDG 3 on health and well-being. And that also shows the importance that India attaches to health as part of human development. So with that short introduction, I'm gonna leave you to today's deliberations that are much more technical and for people who know really how to make these outcomes happen. I just commend all partners for coming together and reiterating this request that really stakeholder engagement be very tight to enable timely completion of all goals of the project. Thank you.
Thank you very much, Ines, for your thoughts and the powerful message that you have today for us. I invite now Dr. Manuel Sotelo, is the active sub-regional director for the Pan American Health Organization, World Health Organization in the Caribbean office. Please, Dr. Sotelo, the floor is yours. Hello, Dr. Sotelo. We're not hearing you. Yeah, you are still in mute. Could you please check that? Okay, Dr. Sotelo. In the meantime, we are waiting for Dr. Manuel Sotelo solving the inconvenience. We are inviting Helen Royer, that is the Director of Human and Social Development in CARICOM Secretariat. Please, Helen, the floor is yours. Welcome.
Good morning. I wish to recognize the presence of Ms. Ines Tufalu, Trust Fund and Project Manager, Specialist, UNOSSC, Dr. Manu Kumar, Political Counselor Representative, Indian High Commission, Guyana, Dr. Juan Manuel Sotelo, Sub-Regional Program Director ad interim, distinguished panelists, Dr. Wendy Emanuelson, Director PANCAP, other representatives from PAHO, WHO, representatives of member states, good morning. On behalf of the Secretary General of the Caribbean Community, CARICOM Secretariat, Dr. Carla Barnett, permit me to warmly greet you as we gather to mark the launch of this important initiative, strengthening of the elimination of mother-to-child transmission plus strategy within maternal and child health. This project is very timely and relevant to the CARICOM community and signals a significant advancement in our public health efforts and our shared commitment to safeguarding the health and well-being of mothers, infants, and future generations across the Caribbean. While the health services have made significant gains over the years, there remains some gaps which need to be addressed to sustain the hard-fought for gains. The region has also made progress in our HIV response, as evident in the achievements of the 95-95-95 goals, and the goal remains collectively working towards the end of AIDS by 2030. The 2024 UN Global AIDS Update indicates that in 2023, the Caribbean treatment coverage has continued to expand, with 85% of people living with HIV knowing their status, 70% of all people living with HIV on treatment, and 61% of all people living with HIV virally suppressed. The report also indicated that the percentage of people living with HIV on treatment and virally suppressed increased from 79% in 2018 to 87%. As a community, we are not only aware of the gaps and challenges that remain in our region's fight against HIV, syphilis, and hepatitis B, but we are taking steps towards minimizing the impact with increased efforts in prevention and advocacy. We are pleased to report that 11 of the 17 countries or territories globally validated for elimination of vertical transmission of both HIV and syphilis are CARICOM member states and associate members, namely Anguilla, Antigua and Barbuda, Bermuda, Cayman Islands, St. Kitts and Nevis, Dominica, St. Vincent and the Grenadines, Belize and Jamaica, St. Kitts and Nevis, and Antigua and Barbuda. This success reflects a strong political will and improvements at both the health system and community levels, contributing to the successful elimination of these diseases. Still, there is much more to be done for syphilis, hepatitis B, and other sexually transmitted infections that are on the rise. As such, the Secretariat welcomes the launch of this project, which presents a comprehensive, coordinated, and integrated approach to addressing HIV, syphilis, and hepatitis B in the maternal and child health programs in our region, with the goal to create a generation free of HIV, syphilis, and hepatitis B in the Caribbean by ensuring that every pregnant woman and her exposed infant receives the necessary care, treatment, and prevention. The Secretariat anticipates that the lessons learned from this project implementation within the maternal and child health program in member states will be crucial as the region works to eliminate these diseases from the wider population. The region stands at the brink of a remarkable transformation where we firmly believe that several diseases can be eliminated, from the EMTCT of hepatitis B and viral hepatitis to tuberculosis and cervical cancer. We have the power and the resources to eradicate these diseases that remain a public health threat. As we gather here today, it is important to acknowledge the progress made by other countries within the PAHO sub-region, such as Brazil, El Salvador, and Colombia, who have launched their roadmaps for multi-disease elimination. These examples inspire us and provide valuable lessons as we chart our course forward. In our own region, the CARICOM region, Guyana has set an excellent precedent with the establishment of a national disease elimination working group and a robust roadmap that prioritizes integrated actions. As such, this project is highly relevant to CARICOM member states as it seeks to strengthen the strategy within our maternal and child health services. Through collaborative efforts, healthcare services will be strengthened, enhanced surveillance will be implemented, and a shared responsibility among stakeholders will be cultivated. The CARICOM Secretariat anticipates continued unwavering dedication to building a healthier, disease-free Caribbean. We extend thanks to the Pan American Health Organization for their continued investment in health and the member states for their participation in this crucial initiative and the continued commitment to support implementation at their local jurisdiction. Let us work hand in hand to realize the vision of a safe and healthy environment across the region. Thank you.
Thank you very much, Helen, for your words. And now we have connected Dr. Manuel Sotelo that will have the opening remarks from the Pan American Health Organization. Please, Dr. Sotelo, the floor is yours.
Thank you, Rodolfo, and greetings. I wish you an inspiring good morning to everyone. Director of Human and Social Development at the CARICOM Secretariat, Helen Roger. Representatives from the Indian High Commissioner of Guyana, Mr. Kumar, other distinguished guests. I also greet Ines Tofalo, Trust Fund and Project Management Specialist from the United Nations Office of South-South Cooperation, representatives from the different ministries of health across the region, Sandra Jones, Leandro Sereno, Mónica Alonso, Rodolfo Gomez, and other PAHO colleagues, representatives of the media, esteemed ladies and gentlemen. Today is a momentous occasion, and I'm honored to be part of it, joining partners, member states, and territories in launching this very special project, strengthening of the elimination of mother-to-child transmission, strategy within maternal and child health services for member states and territories in the Caribbean, and the intensified actions for congenital syphilis elimination. This important initiative is financially supported by the Indian United Nations Development Partnership Fund and managed by the United Nations Office of South-South Cooperation. And PAHO is deeply committed and excited with this collaboration. Together, we strive to improve the health of women and children in the Caribbean by eliminating the mother-to-child transmission of HIV, syphilis, and hepatitis B. This effort is a commitment to a future where no child is born with these infections, ensuring healthier generations to come. Furthermore, the elimination of mother-to-child transmission of these diseases is a key pillar of the broader elimination agenda, a top priority for PAHO. By addressing this challenge head-on, we are moving closer to the Caribbean, where every mother and child can thrive and live free from these infections. The Caribbean region has a long and dynamic history of working collectively through various forms of collaboration, which have resulted in many successful initiatives and advancement in public health. The project being launched here today builds on past collaborative experience in the region and is just one more example of how the Caribbean is uniting to address public health threats such as syphilis and the elimination of diseases that are from mother to child. Today, we are not just here to launch this vital project, but we are also here to address and discuss critical challenges that could threaten the progress of Caribbean has made in eliminating mother-to-child transmission of congenital syphilis. While I will not elaborate on the concerning increase at this moment, it is an issue that will be explored further in one of the upcoming presentations. Despite the achievements and advances in the Caribbean for EMTCT, some member states have seen a remarkable increase of syphilis cases among pregnant women. As a result, we are seeing an increase in congenital syphilis, which puts at risk the certification status of countries that have already achieved validation in the Caribbean. I am sure you'll agree that the antenatal population serves as a reflection of broader trends in the general population. Therefore, if we are seeing an increase of syphilis in pregnant women, there is a need for us to stop and take stock of what is happening and implement evidence-based interventions. Let's not forget that the elimination of the mother-to-child transmission of syphilis and other such diseases is a step towards elimination of this disease for the general population. Addressing this crisis requires an urgent, comprehensive, and coordinating approach that strengthens access to syphilis screening and timely treatment for the general population and key populations, while focusing on pregnant women and their partners, leveraging primary healthcare system. With this implementation of this project, we expect to see a strengthened intervention, not only for pregnant women, but also broader progress towards the ultimate goal, eliminating syphilis in the region. In closing, I pledge PAHO's continued commitment to working with countries, providing technical guidance and support to scale up interventions aimed at reducing new cases of syphilis and congenital syphilis in the Caribbean. Thank you for your attention, and I hope the webinar will yield very successful and useful discussions that are guided the next steps to addressing this critical public health threat. Thank you so much.
Thank you very much, Dr. Sotelo. And now we are going deeper in the agenda, and I invite Sandra Jones, our colleague from PAHO, the advisor in the Pan American Health Organization in the Caribbean office, to show the launching of the regional project, strengthening MTCT Plus, strategy within MCH. Please go ahead, Sandra, the floor is yours.
Thank you very much, Rodolfo. Can you tell me if you're seeing my screen correctly?
Yes, now we can see that in the presentation mode. Perfect.
And it's showing correctly?
Yes.
Okay,
correct.
I don't need to switch the mode.
But now you are back.
Okay, let me see.
You have to switch to the presentation mode, please. That was correct previously.
All right, and
Now
I
it's
don't
correct
need to
again.
switch. Do I need to switch the screens?
That is perfect.
Okay, all
Go
right. So all protocol established. Good morning, everyone, and thank you very much for joining this webinar today. Oops, what did I do here? Sorry, Rodolfo, I have to do this again because I messed up something here. Let me stop sharing again. Okay, oh my gosh, what did I do? You're not seeing my presentation, are you?
We see the presentation, but not in the presentation mode.
Okay, are you seeing it in presentation mode now?
Now is correct, yes.
Okay, all right, so I'll go again and
Go ahead.
thank you very much. Good morning, everyone, and thanks very much for joining this webinar. We know that the disease elimination is a priority for the Caribbean, especially the mother-to-child transmission of diseases. And today we hope that this project, which is being launched this morning, will bring the Caribbean closer to the goal of ending these diseases, HIV, syphilis, and hepatitis as a public health threat in the region. I will first just go directly into an overview of the project, as well as the objectives and the output before the launch of the project. I will not spend some time going into the overview of the Indian UN Development Partnership Fund, because those were addressed by the previous presenters. So in order to maximize time, I will just advance forward. This slide here is just to really show, and I think Dr. Kumar spoke about it, that there are a number of countries in the Latin America and the Caribbean region that are participating in this fund, and it is there to support the achievement of the SDGs. So I will go now into the meat of the project. We know that the Caribbean, as Dr. Soteyo just mentioned, has a long history of working collaboratively to achieve regional health outcomes. And the prevention of the mother-to-child transmission of HIV within MCH, we all know, advanced in the Caribbean through strong technical cooperation among countries. This project, which is being launched today, will continue such efforts, bringing countries and territories together to share their experiences from a health system perspective in the primary prevention and treatment services, laboratory services, and surveillance, coupled with other essential activities with the overall aim of maintaining the gains while supporting other countries to advance to the elimination of the mother-to-child transmission of these diseases. The EMTCT strategy supports the full integration of primary prevention for HIV, syphilis, and hepatitis B within the maternal and child health services, and as such, requires a health systems and interprogrammatic approach for a broad range of comprehensive services. This project today is therefore expected to support a health system strengthening approach to ensure continued and uninterrupted access to service that delivers quality primary prevention and treatment for the seropositive pregnant woman, her partner, and the exposed infants. So we'll take a time now to look at the project, which is to strengthen the EMTCT plus. And when we say EMTCT plus, it's the HIV, syphilis, and hepatitis B within the whole framework of the maternal and child health. The concept note, which is the first phase of actually developing this project, was submitted by Belize on behalf of CARICOM member state, and the project was addressed to specifically address the gaps and challenges that were identified at country level during the process of preparing for EMTCT validation, and which has the potential to undermine some of the gains, as well as delaying other countries that are in the pipeline for validation. Expertise for the implementation of the project will be provided by participating partners such as PANCAP and the Caribbean MedLab Foundation, of course, in collaboration with PAHO, that is the implementing agency. Healthcare providers from recipient countries will also support the implementation of the activities, which will be detailed in a work plan to be developed by individual countries. The PAHO Sub-Regional Office, with the technical support of our PAHO advisors from headquarters, will also support the coordination of these activities and the overall monitoring and evaluation of the project. The overall objective of the project is to strengthen maternal and child health services to continue to provide primary prevention and treatment services to pregnant women, their partners, and the exposed infants to ensure a generation free of HIV, syphilis, and hepatitis B. So now we'll take some time to just go through the three main outputs of the project, which focus on the functional criteria for the elimination of EMTCT+. I will summarize this very quickly. And the first output focus on services and programs and place attention on the increased leadership and capacity of maternal and child health to attain the EMTCT certification for those on the path to validation and to maintain the gains for those countries that have already been validated. And this is important because validation is not a one-time process. As I mentioned earlier, I will not go through all the key activities, but highlight here, emphasis under this output will will focus on integrating the National Immunization Program into the strategy to facilitate EMTCT of hepatitis B. My colleague will talk more about this shortly. And it will also focus on the strengthening of the structures to continue to provide quality service to the target population while establishing mechanisms for the ongoing monitoring of the strategy, of course, within the framework of maternal and child health. During the project, technical support will be provided by countries to advance to the EMTCT+. And this is a process that we have already started with some countries late last year. The second output focus on laboratory strengthening, which is another functional criteria for validation and maintaining the EMTCT+ certification. The focus here is to strengthen laboratory capacity in countries, and the emphasis will focus on quality management system to ensure the quality of test results This includes external quality assurance, specifically for hepatitis B, the availability of rapid test kits, while increasing the capacities of countries to utilize the test kits for HIV, syphilis, and hepatitis B, so as to ensure timely diagnosis and treatment, and where gaps currently exist for people who are not tested in a timely manner, all supporting the establishment of appropriate algorithm as is necessary, and of course, to support access to point-of-care tests for HIV, syphilis, and hepatitis B. Support will also be provided to selected countries for adopting national laboratory policies, and support to the Tier 1 requirement, which is a stepwise approach towards laboratory accreditation. The last output, which is output 3, focus on strengthening of surveillance within maternal and child health, supporting the monitoring and evaluation of the strategy at the national level. The new system is not proposed, but based on the system currently available, it is anticipated that technical support will be provided for the strengthening of appropriate surveillance, which currently exists at country level. In order to do this, the project will make available appropriate equipment to support facilities in communities that are experiencing difficulty with the data collection and, of course, the monitoring of cases. The EMTCT Plus project is framed within the PANCAP regional framework for HIV/STI. It is focusing on addressing the strengthening the EMTCT Plus, as I mentioned, from a health system approach for countries to advance towards the achievement of EMTCT Plus, or to maintain the gains. And I must highlight here, and I think this was said earlier by Dr. Sotelo, that the EMTCT Plus is within the broader framework of the elimination initiative. And so we see this as a first step towards ending these diseases as public health threats in the Caribbean and the wider Americas. Having now discussed briefly the project, with this brief background and overview of the project, PAHO, as the implementing agency for the project, which is financially supported by the UN Development Partnership Fund, which you heard earlier. The project is officially launched, and the first activity that we're doing is this webinar, which is addressing the critical issue as it relates to congenital syphilis. The next major activity is a regional workshop, which is scheduled for May, and which will support the elaboration of country-specific plans. And we will continue this discussion through our country offices with the Ministry of Health as we prepare for the upcoming workshop in May. With this, I say thank you very much for your time and attention. And I'm so happy that this project that we have been discussing for many years is now ready, and we are starting the implementation. Thank you very much, and I hand over now to the moderator.
Thank you, Sandra, very much. It's a fantastic launching. Thank you for the clarity and the passion that you put in the presentation. Thank you again. And now we have Leandro Sereno, the advisor for the Pan American Health Organization headquarters for hepatitis, that he will be presenting MTCT for hepatitis B, birth dose, and vaccination coverage. Please, Leandro, the floor is yours. Thank you.
Thank you, Rodolfo, and good morning, everyone. Let me share my screen, please. And yes, I hope you can see well my screen. And we are going to discuss now the components specifically regarding hepatitis B, as Sandra was mentioned, as part of this integrated approach to eliminate mother-to-child transmission of communicable diseases. And I want to start by highlighting the progress that we've made in terms of HIV and syphilis. It was already mentioned. We have 11 countries in the region already validated for the MTCT of HIV and syphilis. And during this process, during this journey, we were able to identify key factors that allow these countries to achieve the elimination and others that are approaching the elimination. And I'd like to highlight the strong interprogrammatic work that allowed this the progress towards the elimination, the high-level political commitment that countries put into achieving this elimination, and also with time, the MTCT component becomes a quality marker of the whole maternal and child health system. So taking these experiences, these opportunities, in addition to the strong and successful the successes and experiences of the robust immunization programs in the region, the idea was to expand this initiative to include other diseases. And the result was the publication of the MTCT Plus, including hepatitis B and Chagas, where Chagas is endemic, but to align this, we decide and define some targets. To align this initiative with HIV and syphilis. So the target for elimination of mother-to-child transmission of hepatitis B is a prevalence of hepatitis B among children 5 years old below 0.1%. No? And to achieve this target, we also need to implement some interventions, and programmatic objectives regarding the coverage of this intervention. So we have for HIV and syphilis, as I already mentioned, coverage for treatment, coverage for screening, and for hepatitis B, the main intervention is the vaccine. So the coverage of the birth dose, which is the vaccine that is administered within the first 24 hours after the delivery, and also the third dose to complete the schedule, the vaccination schedule with 3 doses within the first year of life. And so we have in the region, as I mentioned, a very robust, very strong immunization programs for all the vaccines, including here hepatitis B. And we can hear here in the history of the past decade, the region of the Americas has a consistently high coverage of this vaccine. Now, for the third dose, which is the dose that's administered in the first year, now it's combined with the penta and hexavalent vaccine. So it's an opportunity also to achieve high coverage of the vaccine. So 87% approaching the targets, and also the birth dose also very high, around 71%, with still some gaps that we need to close. No, and regarding the countries that are introducing for the third dose, all countries in the region have introduced the vaccine hepatitis B in the first year of life, and 33 out of 49 countries that reported the data, they also have the birth dose, which is now one of the challenges and the priorities that we are working on, is to expand the birth dose and to expand the adoption of this intervention in countries, including the Caribbean, as I'm going to show in a few minutes. So as a result of this long introduction, decades of introduction of hepatitis B vaccine and high coverage in the region was able to reduce the prevalence of hepatitis B among children from almost 1% in the late 90s before the introduction of the vaccines to 0.06, which is below the target that we've defined a few slides ago, which is 0.1%. So as a whole, the region maybe might have achieved this elimination target, and depending on the models and based on the mathematical models that we run with the data that is available, we estimate that additional 17 countries may have achieved this targets of elimination at the national level. No? So now it's a challenge that we want to work, and it's part of this project that Sander just presented, to support countries to demonstrate the achievement of these targets, to demonstrate the prevalence below 0.1%. We believe that additional countries not listed here may also have achieved it, but we lack information to run the model with data collection, data generation, so we can demonstrate these and validate certified countries for elimination. When we look specifically for the Caribbean, we also see the very high coverage, even higher from the average region, on the hepatitis vaccine, the 3 doses here, and also the birth dose increasing, especially in recent years as more countries were adopting this intervention. I just want to highlight here that this graphic just consider the countries that report data. So we still may have some lack of information, but nonetheless, the coverage is high in the Caribbean, and we are seeing more countries adopting this intervention. So for example, here, out of the non-Latin Caribbeans, 22 countries reporting, we have 16 that have already introducing the universal birth doses. Most of these, or several of these countries, have introduced this policy in the past few years, especially after the publication of the MTCT Plus, and that's a policy uptake integrated with the MTCT of HIV and syphilis. So we've seen as an opportunity to scale up this intervention. And the countries, including the countries that were able to introduce recently, they are already achieving very high coverage. Now, we have more countries with the vaccine introduced. We have more countries reporting data. We still have some gap of information with at least 3 or 4 countries that have the intervention, but they are not reporting the data. But still, countries are achieving very high coverage very quickly. So it's an opportunity, and we need to leverage on this to advance the elimination. And we know that the vaccines, both the birth dose and the 3 dose, are the basis of this intervention. So they are like the most important interventions, the most efficient intervention to prevent the mother-to-child transmission. We can reduce it 90% the risk of transmission of hepatitis B from mother to child just with the vaccines. But then we still have another 10% that may be at risk. But we have additional interventions that may close this gap and achieve virtually 99% of protection for babies of mothers living with hepatitis. So, and those interventions are, in addition to the hepatitis B vaccination that should be administered universally to all babies born in a country, we also need to include, we encourage countries to include the screening of hepatitis B during antenatal care. So we are already screening for syphilis, we are already screening for HIV, and we also may use this opportunity to add one more screening as part of the panel to test for hepatitis B. And we are able to identify these women living with hepatitis B, pregnant women living with hepatitis B, and then we can add additional interventions, including the immunoglobulin and also the antiviral treatment or prophylaxis for women living with hepatitis B. So we can even further improve and reduce the chances of vertical transmission. And we have additional guidelines that were recently updated by WHO, and these guidelines, they have been simplified and more flexible now to allow the introduction of this treatment for women, because in the past, it was recommended only for women with high viral load, that those are the women with the highest risk to transmit to their babies. But then we have limitations in terms of the availability of viral load tests or the availability of diagnostics confirmatory tests for hepatitis B. And now we have different scenarios that we can consider. So if a country, in the settings that we don't have viral loads or DNA tests available for hepatitis B, we can consider offering treatment for all women that have a diagnosis positive for hepatitis B. So we don't need to do that additional test. So that's a welcome update to allow us to expand even further the treatment for pregnant women and to increase and reducing reducing the chances and the risk for vertical transmission. And in terms of the challenges and the priorities and some of the recommendations that we encourage countries, especially in the Caribbean, to consider, even to further expand the MTCT plus and to respond to hepatitis, as we need a vertical. We need a programmatic, interprogrammatic approach to achieve the MTCT for across the different diseases. Now, in most contexts, in several contexts, we have a verticality, a situation that programs, they work vertically without integration. And then we need to revert this to include even more stakeholders at the national level. Now for MTCT, we're talking about NCH and hepatitis and STIs, but now we are bringing on board immunization programs, primary health care. So we need to discuss across our different departments and include a lot of more stakeholders to discuss and to define strategies and plans to achieve the elimination in an integrated approach. And specifically for hepatitis B, we need to expand access and coverage to services. Now we need to rely and leverage on point-of-care technologies, rapid tests, and now we have rapid tests that are combined with HIV and syphilis. So one single rapid test at the point of care, you can screen those women, pregnant women, for all the 3 diseases, and then define the strategies and define the interventions that they need in case of some if a woman is positive. But even for hepatitis, we also have the vaccination. So I didn't mention, but if a woman is negative and the vaccine is available, we can vaccinate the woman. So we are already protecting the mother before she's infected, because we have the vaccine available. And specifically for the vaccine, the birth dose, as I mentioned, this is one of the priorities to expand the adoption and the coverage of the birth dose. We encourage countries to continue considering the introduction of the birth dose. We have a few countries that needs to adopt this policy, and to help countries increasing and expand the coverage of the vaccine. We need to educate the healthcare workers. Now we need to train them to ensure that the vaccine is given within the first 24 hours, where is the most efficient to reduce and to prevent the transmission. We also need to work with the private sectors. There are some countries with gaps in the coverage when the baby is born in the private sector. So we need to make sure that the vaccine is available in both private and public sectors. And we also, as part of the immunization, the vaccination programs need to raise awareness towards vaccination among pregnant women, their families, and among the community as a whole. Now we have recently observing challenges regarding the vaccines and concerns regarding the safeties of vaccines in the populations, in the community. So we need to be on top of this and on that and to respond. And as part of hepatitis B as well, especially because the first dose is in the first day of life of the baby. So a lot of mothers and families may be concerned, and we need to talk to them before they deliver during antenatal care, so they are prepared and not resistant to receive the vaccination. So, and as I mentioned, just to conclude, as I mentioned, as part of this project, we also want to support countries in generating the information that will demonstrate that they have achieved the targets, especially the impact target, the prevalence among 5 years old. So we can support countries in improving and strengthening the data collection reporting. They need to collect some programmatic data. They need to report on the vaccination coverage, the screening coverage. And with that information, we can support countries on this. And also, if needed, we can discuss and review on case by case if it's needed to have some survey in order to generate that information. And we will be doing this as part of this project as well, with the objective now to confirm that countries have eliminated hepatitis B and certify these countries together, hopefully with HIV and syphilis. Thank you.
Thank you very much, Leandro, with the fantastic and clear presentation.
I can't hear you, Rodolfo. Sorry.
On hepatitis. Thank you very much. We need to change a little bit the agenda because our colleague Natalia Beer from the Maternal and Child Health Department from Belize have to have a competing meeting for an emergency. Before we invite our colleague Monica Alonso, we changed the order. We will start with the country experiences, analyzing barriers and challenges for congenital syphilis elimination. We invite Belize and Natalia, please, the floor is yours. Thank you very much for your flexibility. Thank you. Please go ahead.
Thank you, Rodolfo. Can you see my presentation?
Yes, clear. Go ahead.
All right, I would just like to start in the name of the CARICOM member states and people. We extend our sincere gratitude to the people and the government of India for their support to EMTCT in the Caribbean, and also to PAHO as the implementing agency. I like to use this, the impact of little feet transforming nations, because applying for validation really shook the entire health system, public and private and other providers. Barriers and challenges in health, like any other health problem that we are facing, can limit access to care, can have problems with quality of care, and can have negative outcomes that has to do with the overall well-being of persons. We use the congenital syphilis surveillance case definition that appear in the Orange Book. We do screening routinely 3 times during pregnancy, at first contact with prenatal care, at a 3rd trimester, prenatal care, and then upon admission for delivery. For women with risk factors for STIs, then a second screening is done between test 1 and 3, first contact and 3rd trimester. What have worked for us very good is that the screening test is included in the prenatal lab panel in the public and private health sectors. And of course, the definition of treating women at least 30 days prior to delivery is one of the milestones that we pursue. I share this tracking spreadsheet because what we do is on one row, we have each case and we track according to protocol all the different services that are needed. And this have been very helpful for us in ensuring that women get timely services and support as needed. There is evidence that worldwide, there is an increase in the cases of syphilis in general, and this is also replicated during pregnancy. It's an ongoing public health problem. We know that congenital syphilis can lead to stillbirth, miscarriage, preterm birth, birth defects, lifelong physical or neurological changes. So it is of utmost importance that medical practitioners apply the evidence that is being recommended through the different documents produced by experts and expert organizations like WHO. Recommendation number 4 speaks to on-site syphilis tests and if positive provision of a first dose of treatment. We are not there yet. I mean, we have limitations with human resources, and having the syphilis screening as part of the prenatal care panel of labs that are done works pretty good for us. Syphilis during pregnancy, the evidence is there. We don't need to repeat it. Time is of essence between diagnosis and treatment. And in Belize, the test and the treatment for syphilis is treated as a public good. Even if the woman goes to private, she can access these from the public sector. There are economic barriers, but Belize, even before being validated, removed all fees from public hospitals promoting universal healthcare access, including services for EMTCT. Geographical barriers, we have 232 communities, and we provide mobile clinics every 4 to 8 weeks, including access to prenatal care. We have a diverse community with different ethnicity, each one needing to be culturally sensitive for the interventions applied there, although English and Spanish is the major languages. Education is can be a barrier, not only education, but all the other different social determinants of health, but these are outside of the Ministry of Health Control, hence the reason for us to ensure that we apply the protocols every time we're in contact with pregnant women. There were other barriers. 52% of our population live in rural communities, low literacy and poor access to telecommunications will difficult their access to digital communication activities or information that we share. But we have seen an increased support from family members for pregnant women to access services within the EMTCT. So we have the basic inputs, data source, we have multiple data sources for constructing the indicators. Every consultation room have access to this Jabed tool that help the staff navigate through the different concepts for the management and classification of the cases. And the National Validation Committee, even before being validated, recommended that the data collection for EMTCT should be collected at a single event, in this case, childbirth attendance, because women sometimes choose to go private, public, NGO, and it makes it difficult for us to have these correct data. So I am proud to share that since July 2023, even before being validated, we did modifications to the live birth registration at the birthing centers, and that is being used currently in public sector, private sector, and others that are providing childbirth attendance. Other challenges in the health system, long waiting time, we still need to work on that. We're working on staff shortages, underfunded healthcare. Nonetheless, services are being provided at clinics and during mobile clinics. One thing we learned is that, yes, the maternal and child health need to spearhead the EMTCT because we deal with the target population, but we cannot achieve validation if we do not have all the staff involved in EMTCT, public and private, and at all entry points. And this is a lesson learned from preparations for the validation. Born free of HIV, syphilis, hepatitis B, hepatitis C, whatever other perinatally transmitted disease is a right of every child. This is enshrined in the Article 24 of the CRC. And our process for validation, we see it as an opportunity to improve the quality of services and health outcomes, because we had to do a lot, even at the legal level, to be able to be validated. So more than a lot of work is an opportunity to save lives. Thanks very much.
Thank you, Natalia, very much for your enthusiasm, and the good news that you share is making us, see the light in the tunnel. Thank you very much. And now we are coming back to the original agenda. I invite Monica Alonso, is the unit chief of the CDE at PAHO headquarters, to present the situation of syphilis and congenital syphilis in the Americas and the Caribbean, and the recommended strategies to reduce new infections and maintenance of the MTCT of syphilis. Please, Monica, go ahead.
Thank you so much, Rodolfo. Greetings, Mr. Kumar, Dr. Arroyo, Ms. Tofalo, Dr. Scott, Dr. Beer, and Dr. Sotelo, and esteemed colleagues from the Caribbean, colleagues from PAHO. It's a pleasure to be here. I will be sharing my presentation, putting it in presentation mode. And without further ado, I will provide an overview of the situation of syphilis and congenital syphilis in the Caribbean, and be discussing what strategies we can implement to maintain elimination and advance to elimination in those countries that haven't yet been validated. So this is just the overarching framework for EMTCT, for HIV, syphilis, Chagas disease, and hepatitis B that we have been discussing in prior presentations. And I will be referring mostly to the impact target for congenital syphilis of under 0.5 congenital syphilis cases per 100 live births, and those programmatic objectives that are needed in order also to achieve the validation of over 95% coverage of ANC and hospital deliveries, under 10% of unmet family planning needs among women 15 to 49 years old, as that's the way it's the indicator is measured, and over 95% coverage of syphilis testing and treatment in those that are positive. So we do have some concerning data on the estimates that WHO developed for data referring to 2022 that shows that the Americas is having the highest syphilis burden throughout the different regions of the world. And there we can see the values of syphilis incidence rate in males and females for the Americas. That is of over 6 per 1,000, higher than Africa and higher than the other Eastern Mediterranean, Europe, and Asia and Western Pacific regions. Specifically for the Caribbean, the values are lower, as we can see here, 3.99 and 3.98 for males and females, but as you can see, it's still an estimate that is quite high. So there was the estimate that in 2022, there were 41,000 estimated syphilis infections in the Caribbean. And we will be looking at the overall syphilis situation, but also at the congenital syphilis situation. But as we will see, they are quite interlinked. So here we have more estimates. And there will be a little bit of a discordant information that I will be putting forward. So here is the estimates up to 2022 of the prevalence of syphilis in pregnant women in the blue bars, and the incidence of congenital syphilis in the red line. And so the estimates indicate that the prevalence of syphilis among pregnant women has decreased slightly, with more or less a stability in the last years, with a parallel decreasing trend in congenital syphilis cases. Now, mind you, these are the estimates. What we're seeing with regards to prevalence of syphilis among pregnant women in the Caribbean, and we're comparing a time point of 2015, 2016, which is in blue, and 2021, 2023, approximately, which is in red. And we see a varying picture depending on the countries. So in some countries, like Haiti, Jamaica, St. Lucia, and St. Vincent, we see a decrease in syphilis prevalence among pregnant women. You can see that the red bars are lower than the blue bars for each corresponding country. But we have another set of countries, and also Barbados with a lower value for the most recent years. But we have another set of countries where we're seeing an increase in syphilis levels among pregnant women. And why do I point this out? Because this phenomenon is also occurring outside of the Caribbean, in North America and in Central America and South America, where we are seeing spikes and increases in syphilis prevalence levels among pregnant women and among other populations. So this is something that is very important to be monitoring. And with regards to congenital syphilis cases, we are seeing these are reported cases. So if you recall, the estimates showed a decreasing trend, which is something that we will be working on with WHO to review that data, because with regards to the reported data, which are the actual numbers of babies born or stillbirths that are congenital syphilis cases, we are seeing in the last 4 years an increase in values compared to the 2012 to 2019 values, and a corresponding increase in those rates for the Caribbean. The reported syphilis prevalence in pregnant women, according to the last available year reported, we can see that ranges from 0%, no cases found among pregnant women, to a prevalence level of 2.1% in Haiti. This is also an important consideration because if you achieve 95% ANC coverage, 95% screening of pregnant women, and 95% treatment of for syphilis, you have that 5% that would be skipped, right? That of those women that are falling through the cracks. So if you have a very high prevalence level of syphilis among pregnant women, over 0.6%, then you will risk having syphilis among those pregnant women that don't go to ANC or that are not screened or that are not tested. And that will result in a congenital syphilis rate that is over the target that we want. Meaning that even if you reach those milestones, if you have a very high level of syphilis circulating in your community and among pregnant women, you will not be able to reach the elimination target. That's why it's very important to also monitor these levels and make sure that we address syphilis in the community, in women of childbearing age, and of course, afterwards in pregnant women in the ANC services. So what I'm referring to is that we have to work very, very hard at the ANC platform, but also primary prevention of syphilis is also important in situations that we are facing in the Americas of these spikes in syphilis in the community. And here also in key populations, we see very, very high levels. We don't have values for trends, but we do see very high levels among MSM, female sex workers, and transgender women of syphilis. But in addition to these key populations, which are the traditional key populations that we work with, for example, for HIV and for syphilis, we are seeing high levels of syphilis in other populations such as migrant workers or truck drivers or persons working in settings that makes them be away from their families, etc., or young people as well. Here is a summary, and I'm not going to go over this very complex table, but I do want to point out a couple of things, is a summary of the mapping we did regarding policies in the Caribbean for syphilis screening and treatment among pregnant women. So thank you for all the countries that responded to this questionnaire. Here we have the results, and not only we are showing them to you now, but we're also working, and we want to put forth a publication so that there's more attention, right, to this health topic. So I did want to point out, as Dr. Beer was mentioning, the rapid test, which is the third column, and she was mentioning it that in context of high prevalence of syphilis, WHO recommends the use of rapid test. So that can be in certain subpopulations or in certain geographic areas, etc., where it would be very important to be able to count with rapid tests because they are point of care tests that can be conducted right then and there, and then you can get the result and treat the pregnant women and their partner if necessary. So those are some of the elements that we are monitoring and that can make a difference when we are on the path to elimination or maintenance of elimination. Here we see the extremely good results of the percentage of screening and treatment for syphilis in pregnant women. So we have in the red line the coverage of treatment of all those pregnant women that were syphilis positive, reaching 100% reported in 2023. And in the orange bars, we see a very high coverage of screening for syphilis among pregnant women. But just to mention that we see here in 2023, we achieved 93%, which is a very good and very high value. But if we are facing increasing levels of syphilis circulating among women of childbearing age, and then those women get pregnant, you still have that 7%, right, that would not be screened, and that could result in a congenital syphilis case. We, among other elements that we can count with, we have this incredible tool, which is the SIP, that has been around for a long time, but now it's called the SIP Plus. And why is it called SIP Plus? Because it has been upgraded to an online information system that can be used as information is being collected, and you can have the analysis right there and then. And this SIP Perinatal Plus also enables you to have all the EMTCT Plus indicators in actually a one-click situation. And there is an online course for the SIP Plus developed by our colleagues from the Latin American Center for Perinatology, Women and Reproductive Health. And we also encourage you to access this course to understand more about the perinatal information system. So it is a clinical record that is being used in the Caribbean, and we can see here that many of the countries not only are using SIP, but they have evolved, as we can see in yellow, the countries, not in yellow, excuse me. We can see countries, I think there's some arrows there. That's what I was missing. We can see the countries from the Caribbean that are in the green arrows that are using SIP Plus, which is the more advanced online version. And in addition to the online course for SIP Plus, we also have developed an online course for the elimination of congenital syphilis, ensuring adequate diagnosis and treatment. And this course has not only been used in the Americas, which was developed by the CLAP Center and also by the rest of the colleagues. Sandra Jones also led it, and the PAHO office in Jamaica. But it has even gone global, and we have participants from many other countries in the world. But in the Caribbean, we have persons, health workers with mainly nursing professionals, also medical, general doctors, and other health professionals that have been taking this course from Jamaica, Trinidad, Tobago, Belize, and St. Lucia. So this is also an important tool that we can use to improve practice for the elimination of congenital syphilis. So in summary, we are going to refer to what strategies with this situation, with this a little bit, this concern of these rising syphilis rates that we're seeing in many of the countries, albeit maybe not all the countries, but we do have to be aware, right, that this is happening very close to many of the borders. So one of the very important strategy is to address pregnant women and their partners, right, with testing and treatment. Importantly, to decrease the circulation of syphilis in the rest of the populations. And we have to be looking not only at key populations that do have a very high burden, but also be thinking of young women and men and different subpopulations that might be at higher risk and have higher syphilis prevalence. Very, very important to have this risk communication. For the health providers, some providers in the Americas think that syphilis is a situation of the past, so they are not aware, they're not really cognizant of what is happening, and also for the general population, for pregnant women, for their partners, and for the general population on the situation of syphilis. As we mentioned before, we have these tools that can enable us to reach those that might be falling through the cracks. So we have the rapid point of care test that can be done outside of the lab. Very important of the integration of responses with HIV, with persons that access PrEP, for the persons living with HIV. And also very important to remind or to reinforce or recoup the strategies for condom use. We are collecting data, and we think at least some of the data that we're seeing that indicates a little bit of a decrease in condom use in our populations throughout the Americas. So to revitalize the messages and the accessibility to condoms is also a very important strategy that sometimes we forget because we have these rapid tests, because we have PrEP for HIV, etc., and maybe we are not talking about condoms enough as we used to. Very importantly, the access to treatment. The penicillin is essential. It's still the mainstay for the treatment of syphilis. No reported resistance. But it's important that the penicillin be available where the patients are, right? So regarding stockouts, some countries, and not in the Caribbean, but in some countries that I have visited, the policy is to provide penicillin, but then you visit a health center and they tell you, oh, we ran out, so we provide we tell the pregnant woman to go to the pharmacy there in the corner and pay for the penicillin and then come back and provide the test. And that could be a missed opportunity because we don't know if that person is going to come back. But not only for pregnant women and their partners, there should be a reconsideration of the policies for free test and free treatment for syphilis, especially in this with these concerns of rising syphilis, to make sure that we have the syphilis in check throughout all our populations, to ensure that truly we maintain congenital syphilis elimination. Also, of course, to address social determinants of health and stigma and discrimination with regards to STIs and HIV. And there will be new technologies. WHO has a guideline group to provide recommendations for doxy-PEP, which is doxycycline provided to persons that at high risk for STIs as a preventive strategy. And we also have the dual self-testing of HIV and syphilis, which we do have the dual HIV syphilis test, and some countries are using that dual test, but also it will be coming in a self-testing format. So here's just a summary, maybe in a little nicer presentation, but it is similar to what we were talking about, but this is also important to discuss, that not only think about the providers, the government, but really liaise with the communities. We talked a little bit about risk communication, but the communities, there's a lot that communities can do together with governments as part of the path for congenital syphilis elimination. So it's very important to have them engaged and in the dialogue. So thank you very much for being able to present to you, and I remain available for any questions.
Thank you very much, Monica. It's a fantastic, clear presentation. Thank you. And now we have, few minutes for questions and answers. We have here in Q&A the first two. I invite you, the 250 people that are enrolled in this webinar, just to write in the questions and answer if you have a particular question for the panel. Leandro, we will start with you. One person asked if you can talk a little more about the use of hepatitis B immunoglobulin. I think that we'll be focusing maybe in positive pregnant women in the prevention of the transmission. And maybe if you can add a little more for the vaccine for pregnant women. Thank you.
Okay, thank you, Rodolfo. Thank you for the question. And yes, the immunoglobulin is part of these additional interventions that we've mentioned. Now, the basis of the pyramid, the most important intervention are the vaccines that should be administered universally to all children. And to those women who are positive and the babies, we need to include additional interventions in the immunoglobulin to even further prevent the transmission for that woman. With the immunoglobulin, we have like 96-95% reduction of the risk of transmission. And if we add the treatment for during pregnancy, we can achieve 95%. The immunoglobulin, the ideal is to be given in the first 2 days. It can be efficient until 7 days, but I think the most efficacy is within the first 48 hours. And it can also be administered in other exposure situations, like healthcare workers that they had accidents, contact with blood of infected people. They could use immunoglobulin as well, but we are focusing here today on the antenatal care. And also you mentioned, so re-emphasize, we can offer the screening for pregnant women for hepatitis B, as we do for HIV and syphilis. If a woman is positive, then we need to assess what we need to do, like to confirm diagnosis, to offer treatment, the immunoglobulin, etc. for the babies. And if the woman is negative, we can offer the vaccine. So we can start the vaccination during pregnancy. There is no contraindication, and then we can protect that woman for life after this. Thank you.
Thank you very much. That was very clear. One question that was deleted, but I remember, is for Sandra Jones. The question was related to the estimation, when we will be moving from the estimations, to the real monitoring systems in countries, and how this proposal, this grant, will help countries to tailor-made their interventions according to the monitoring systems. Could you please explain a little more? Thanks.
Right. So let me see how I could address this question. So the meeting that is planned for middle of May, I think it is, I can't remember the exact date, is going to for us to have a discussion with countries as to what exists, what is available in country, because it's not a one-size-fits-all. Different countries have different surveillance system that is established that is already ongoing in place. So it's how can we build on that? So sharing of the experience, we would have countries that will be sharing experiences and good practices of what they are using to monitor the EMTCT plus within their countries, and countries will have the opportunity to understand these and to analyze and to determine what would be best for them. And this is the reason why at this workshop, we will have countries actually develop their work plan, because they will have to determine what it is that they would want to actually advance with. And then as a project, we will try to see how best within the context of the project that we can actually provide support going forward. So I hope that answered the question.
Very clear and loud. Thank you very much. And now for you, Leandro, again, this is a new question related to the quality assurance program for hepatitis B. Is there some recommended quality assurance program?
Yeah, we have different methodologies to ensure the quality for the different components related to hepatitis B. Now, there is for the immunization programs, there is a set of tools and methodologies to ensure the administration, the supply chain, the cold chain for the vaccines that are, I mean, applied to all the vaccines, but there are some specificities also for hepatitis B. So we have these tools. In terms of the MTCT Plus, specifically, for the validation process, we also have some tools regarding the programmatic aspects, the implementation of the MTCT, like programs and services, the data quality, laboratory quality, which also has some standards for quality assurance for the diagnosis of for screening and diagnosis of hepatitis B. So we have these different tools, and they should apply for the different components of the whole hepatitis B response.
Okay, thank you very much. Nadia is very well explained your question. If you don't have any other question in the chat, I can go directly to the next presenter. Will be Valerie Wilson from the Caribbean MedLab Foundation. She will be explaining us the use of technology to support the screening and timely treatment for syphilis in sexually active persons and the antenatal population. Please, Valerie, the floor is yours. Thank you very much. Welcome.
Thank you very much. And I hope that you're seeing my slides. Are they in presentation?
Not yet in presentation mode.
Okay.
We can see the slides, but
right. I think they're in
now
presentation.
is correct.
mode.
Yes.
Thank
Go
you.
ahead, please.
Okay, thank you. And thank you for the opportunity, all protocols observed. And I am very happy to be able to make this presentation this morning. I'm going to try to keep it not too technical, but I am going to be talking a bit about some of the realities of syphilis testing, and of course, the use of rapid tests and the HIV syphilis rapid duo and others, because we are seeing the emergence of tests that are going to test for 3, as Leandro mentioned earlier. The WHO pre-qualified tests and ensuring the quality of rapid testing at point of care. So serological testing for syphilis is not a simple process, unfortunately, because there are different kinds of serological tests that test for the treponemal and the non-treponemal parts of the syphilis. And the non-treponemal serological tests are tests that a lot of people are familiar with, the RPR and the VDRL, and they are very useful to assess the efficacy of therapy. These are the important tests for this purpose. And after successful treatment, you normally find that the titer should show a significant drop, at least a 4-fold drop, or become negative. They're very sensitive, but they lack specificity and may be positive at low titers for other diseases. But if they are high titer, then they generally are indicating syphilis. And they should be confirmed with a more specific treponemal test. These non-treponemal tests are always positive in the untreated person. So as you can see from this diagram, the untreated person is always positive once they have not been treated with a treponemal test. After they've been successfully treated, they become negative, and over time you can see that they become negative. Like I said, you usually see a reduction in titer. When it's very late disease, in late syphilis, you may find that the person might remain, the titer might remain unchanged. And then we have the serological tests that test for treponemal serological parts of the antigen. And these detect the syphilis antibody, and they can confirm exposure to treponemal disease. They're generally considered to be more specific than the non-treponemal tests. There are sometimes some false positive, generally with some connective tissue disorders, but they cannot distinguish between syphilis, for example, and yours. But they remain positive for life, even after successful therapy. And they can become reactive even prior to the non-treponemal test. So that's where they come in. They can come in very useful. And these tests, untreated, they are always positive. When you treat, they remain positive, and that is the key difference between these and the other tests, the tests that we spoke about before, which was the non-treponemals, which actually change when you treat. So using these tests, and these tests, most of the rapid tests are actually using that treponemal antibody. And so pregnant women who are seropositive can be treated actually, because even though we are saying that that antibody may actually remains even after they've been treated, it is more important to treat the pregnant woman to prevent congenital syphilis, and the slight problem of overtreatment is actually not even comparable to what may be the outcome if in fact we have a child who gets syphilis. So the way the algorithm, and algorithms are really important, and this is not a training for you to understand lab business, but I'm just here illustrating how the algorithm actually works when you use those rapid tests in the field. So it's really important. There is a lot of training that goes into ensuring that people know how to use these tests adequately in the field. I've listed here from the WHO diagnostic landscape for STI testing a number of tests so that you can see. It's really not for you to read all of these tests, but it's so that you can see that there are a lot of rapid diagnostic tests for treponemal pallidum detection. And there are many of them that have been approved by the Europeans, have been approved, and there is a list of WHO pre-qualified tests, which I will share with you. So these tests are actually, all of them, commercially available, and they are tests that can be rapidly performed in the field. Often people think because they can be performed in the field that they are so simple that we don't need to worry about quality, but we do need to worry about quality because things can go wrong. The dual HIV syphilis rapid diagnostic test has been promoted by WHO since 2019, also for use in pregnant women, but also, for example, persons who are at high risk of STIs. So the dual HIV syphilis rapid test are a number of them on the market. But even beyond that, apart from the duo tests, you even have tests that are incorporating more than just two. So we have a couple examples here of the HIV and syphilis duo tests, and I'm going to give a list shortly. But you also have what has come on the market is tests that are actually doing testing for hepatitis B, hepatitis C, HIV, and syphilis all in one cassette. So the technology is really advancing very rapidly, and we are seeing the emergence of many options for using rapid tests in the field. As Monica mentioned, the HIV and syphilis self-tests are in the final stages, and we're going to see, we know we have HIV self-tests. Now we're starting to see the emergence of HIV syphilis self-tests. The currently available duo tests for HIV and syphilis use treponemal antigens. So in other words, from what I showed you very early on, those treponemal antigenic tests are going to remain positive even after treatment. But they are very highly specific, and so they are really very good tests. And the algorithm that I showed you earlier is for using those tests in what we call a reverse algorithm, a treponemal and then non-treponemal test. So it can't differentiate between recent and past infection, but as I said earlier, it is more important to treat the pregnant woman and prevent congenital syphilis than to than the concern about overtreatment in a case where she may have been treated previously. So this is a list of HIV syphilis point of care tests, and the ones that are in red are the ones that are on the WHO pre-qualification list, but you have a range of tests that have, you know, a range of manufacturers that are manufacturing these point of care tests for HIV and syphilis. So there are many options available. It is always our advice that you start with a WHO pre-qualified test, and because in fact, you want the reliability and the accuracy of the test to be as high as possible. Then we have the syphilis TREP, non-TREP tests, because that is also one of the tests that's on the market, which actually is a point of care test that should really be able to give you a result that is telling you that you have treponemal, actually being able to measure the treponemal and non-treponemal aspects, which of course should in the final analysis give you whether you truly have a current case of syphilis or not. The performance of the test is still to be verified in the WHO listing. But here's the list of WHO syphilis and HIV syphilis rapid tests. And among the list from WHO, and this was the 2024 list from WHO, the determined syphilis test, the first response syphilis, the standard Q-HIV syphilis combo, the first response HIV syphilis combo, and the BioLine HIV syphilis duo. So three of these, the ones in red, are HIV and syphilis combination tests. They are duo tests. The first two are tests that are actually single syphilis tests. They will just test for the treponemal antibodies for syphilis. So we have, in other words, a lot of options for using these tests in the field. But it is really important to, when establishing rapid testing, to ensure the quality of point of care and what you're actually doing at the point of care. And this is something that is stressed in all of the documentation related to rapid testing, coming from WHO and from other organizations that are providing guidance on the use of these tests, and from ourselves at CMLF. The idea of rapid tests, because they are so simple, again, people think they're so simple, anybody can do them, and so they're always right. No, they're not. The first issue is, of course, select from the WHO pre-qualification list, so that you're starting with a test that has undergone a very extensive pre-qualification to ensure its reliability and so on. You need to verify the performance in the hands of the people who are going to use it, because sometimes people don't follow instructions. They're not able to follow exactly what needs to be done, or you may have very different circumstances. A small verification, not the kind of validation that WHO would have been done. And then to select the appropriate sites in terms of ensuring that you have criteria for the selection of the sites. The criteria, of course, include the kind of storage conditions you might need to have, whether you have persons there who are able to be trained and will be able to do the test, whether you have appropriate space where you can allocate for doing the test, etc. Number of different criteria that you would have to use in order to put the test in place. Of course, you have to train. Training is fundamental, and training involves not just showing people how to do it, of course, but all the necessary documentation that is required to ensure the ongoing quality of the test. And of course, assessing and verifying the competency. And that normally is done annually of the persons who are actually testing, so that you're not just training people up and putting them out there and leaving them there for years to conduct the tests. And of course, the ongoing supervision, monitoring, and including quality control and external quality assessment. And these training, competency, the appropriateness of the site, the ongoing monitoring and supervision, the QC and EQA, these are all areas that are looked at as part of establishing whether the country or the country is meeting the EMTCT requirements for the laboratory. So there are very, very specific requirements. And generally, in order to ensure that the country is meeting these requirements, it's not just at one or two sites. Wherever testing is done for pregnant women, the quality is going to have to be assured. And this is why generally a policy that incorporates all the labs, both public and private, and testing sites is really critical for that assurance of quality at the point of care testing sites. In 2020, we did an evaluation of HIV. These are HIV rapid tests that were done. And you can see that the performance was excellent for all the tests actually that were listed here. WHO sets a bar of 90% sensitivity and specificity. And all of the HIV tests that were done in the evaluation, there were 9 of them, performed extremely well. The region currently uses the determined syphilis, the Abbott determined syphilis, and the Unigol as their algorithm for HIV testing. There was included in that evaluation the syphilis tests and the syphilis duo tests. And the syphilis test that worked really well was the Abbott determined. Some of the duo tests, I think we had some issues with people actually reading the test. It may be that it was the problem, but it did not perform as well, although the specificity of the test, so the sensitivity was in the region of 70 something percent. Specificity was again in the 90s. So this actually did tests within some of the countries in the region. Some of the countries went ahead and did their own verification and introduced these duo tests. But the duo tests, in fact, the opportunity to sexually active persons for HIV and syphilis with one test. So they really are a very big benefit. And I think Monica referred to it in her presentation, how we integrate this into antenatal testing for women, for example, those who present late at sites where referral causes delays. So she showed some data where you were seeing that sometimes it might take a week for a test to come back or more. And testing, of course, of their partners at STI clinics, etc. So not just the pregnant women, but wider than the pregnant women, of course. But for pregnant women in particular, trying to ensure that they get those results back in a very timely manner. In fact, the duo test and use of the syphilis rapid test in general can facilitate same-day treatment for syphilis. And that is an important facet of the rapid tests and the capability of the rapid tests to support the elimination initiative. But getting a titer is still critically important. So those rapid tests are not going to give you a titer. Those are the treponemal tests. They are not going to give you the titer. It's the non-treponemal tests that give you the titer. Those generally are run in the lab. And it is still important as a test for cure to prove that you have actually cured an individual. Remember that the treponemal test is going to stay positive regardless of how long after treatment, whether the treatment was successful or not. But the titer is going to change if the treatment is successful. So it's important as we introduce these tests, and not just introduce because a number of countries are using them, but as we improve the use of these tests to make sure that, because we have seen in places where we have done some of these EMTCT evaluations that, for example, the titer is not being done because they do the rapid test and then they don't worry with the titer, but the titer is important. And it's also important, another thing that we saw, that the duo test does not confirm HIV. It is just like another HIV test, another HIV rapid test, which requires an algorithm for confirmation, just as the syphilis requires an algorithm for you to determine whether in fact it is a recent infection or an old infection. and whether in fact the cure has worked. So for HIV also, it requires the algorithm. So we can't forget when we start introducing these, and sometimes we have seen that people do forget that they do need to continue to introduce these with all the principles that are necessary to ensure quality. Of course, as I said earlier, the test should be selected from the WHO pre-qualified listing. And once they are verified, with a small verification at the national level, the introduction requires the quality management, the monitoring of the sites to maintain quality. I spoke about that already. And the quality control and external quality assessment, EQA monitoring, regular training, competency assessment are essentials to maintain the quality. So those are the real critical things that have to be considered as we expand the use of HIV and syphilis rapid tests at point of care and ensure that they are actually going to be providing us with the results that we really want to see. So I thank you very much.
Thank you very much, Valerie. And the last presenter will be, sharing the country experience, coming back to the barriers and challenges for congenital syphilis elimination from Guyana. That will be Oneka Scott, the Maternal and Child Health Department from Guyana. Please, Oneka, the floor is yours.
Thank you, Rodolfo. Thank you, Rodolfo. It's good to see you again. To my fellow panelists, Sandra, Valerie, Leandro. I think Monica was here as well. It's good to see everyone again. And to my colleagues from around the world, greetings. In the next 10 minutes, we will share with you some of our barriers that we face in Guyana on our path to the elimination of congenital syphilis. We're presenting this in the form of a SWOT analysis because the barriers should not be looked at in isolation. And so we do have some strengths that we want to identify. On our journey to elimination, we've recognized that there is really great increased investment in health and human infrastructure for MCH services in Guyana. There is also an increased Government of Guyana budgetary allocations especially over the last 4 years. The budget allocated to the elimination of diseases, the EMTCT initiative being part of that platform, has increased to a positive front. We also do want to highlight that there is really strong establishment of government partnerships for such delivery of services. But there are some weaknesses, however, and they come under a series that we've grouped as geopolitical factors, some geoeconomical factors, some related to service efficiencies, and others that are culturally biased factors. So just to highlight some of our geopolitical factors, we do have decreased health facilities offering point-of-care testing, especially in our rural areas. Guyana, we share a terrain that resembles much of the Amazon platform, even in our most coastland regions, such as Region 2. So there are some hinterland sub-districts with health infrastructure that's still developing, and as a result of that, the services for syphilis screening are delivered via outreaches that may not always be possible depending on the health infrastructure. Because of that, we have a delayed turnaround in the results for such clients. So you'll find that we do not have early diagnosis in most cases. Under the geo-environmental factors, these same scheduled outreaches may not always be executed because of weather and terrain. In some areas, when it's flooded, you can't access to get any materials in for about 6-7 months. In other areas, you may have very bad roads that will be as a result of flooding. You may also have fog. There's very mountainous regions. And so divisive means have to be constantly employed to ensure that we get services to some of those areas. But for service efficiencies, as another barrier, there are prolonged turnaround times of results. And that's because there is, for some of the coastline regions, we have recognized that there is a hub. So we collect the test at the facility, and then we have to send it to the regional lab. And this is the absence of point of care testing and screening, of course. And then it goes to the reference lab in most cases that has to be sent back to the regional lab and then to the service provider at the test facility. The gap is usually from the regional lab to the service provider, and it depends on some of those same environmental factors that we listed earlier. For service efficiencies, especially for point of care testing and following the needs of the women, and we'll see in cultural barriers in a little while and in the next slide, why skilled healthcare workers are important along the course of our journey for the elimination of congenital syphilis, because we do need social workers. And just like other countries, we have different ethnic groups, and those ethnic groups have different needs. So we may have indigenous groups who need a little bit more attention because of our health literacy barrier. So our social workers and the persons who track the cases to direct them into care and make sure care is followed up are sometimes usually lacking in some of these rural areas. And cultural biases, we've recognized that there is, at the level of the mother, a delay, number one, to seek care. And when we really peel away the reasons that these mothers express, it's simply because they are afraid, maybe because they endure a domestic violence environment, to disclose to their partner that they have a positive test, whether it be HIV or syphilis. Other cases, there's such great stigma associated with STIs that we're finding that more and more of our mothers are refusing such care. And so we have that delay, number one, they enter into care very, very late. But among the threats, we recognize that there is a growing migrant population, and we do have very limited resources to navigate to some of these groups, especially the language barrier. So healthcare workers, again, meet most of our migrant population on outreaches. And if the factors haven't aligned correctly with the stars, then those outreaches are also not executed. Opportunities must be mentioned, that apart from some of the strengths I talked about earlier, which is extreme increased political will, we are committed to the elimination platform and the process and sustaining elimination afterwards. There are investments that have grown along with Guyana's GDP. We have the opportunity of working along with our partners internationally and both nationally. There's great public and private partnership. And then there are government programs that have been targeting the increase and the improvement and expansion of health infrastructure and increase of the health workforce to meet our needs of universal healthcare access. And that brings me to the end of my presentation.
Thank you very much, Dr. Scott. We have few seconds for questions, and maybe one question in the Q&A is for Valerie, is related to how difficult it is to use the dual test implemented kits. Is maybe a programmatic question, but if you can answer the first question, Valerie.
Sure, thank you.
How
Thanks.
difficult it is.
Thanks, Rodolfo. It's not difficult to use those kits. The difference is, though, that to a large extent people have been used to reading one line on the as a positive on the the cartridge that you use to do the rapid test. So it's a bit different, and you just have to get used to the difference. And the important thing, though, is to ensure that people are adequately trained and that you verify that they are able to do it correctly by doing a comparison so that you can make sure. And of course, you do that ongoing monitoring that is necessary to ensure quality, which is always absolutely necessary, regardless of whether you're using a duo test or a single test in a rapid test and point of care testing environment. I hope that answers the question. I
think you answered very clear and loud. With no more questions, and we are run out of the time. We thanks everyone to participate, the 250 people participating, and the enthusiasm that we received from the panelists and from the ministries of health representatives, showing the problems, but showing as well as the lesson learned and the successes. Now we are coming to the end, and for the next steps and closure, we invite our colleague Sandra Jones to do the closing remarks. Sandra, the floor is yours, and thank you for having me as a moderator today. Thank you.
Thank you very much, Rodolphe. I don't want to stand in between anyone and their lunch, so I'm just going to make this very quick. And I would just want to actually express my thanks and appreciation for everyone who actually joined the webinar today, and we appreciate all the questions that were asked. In terms of the next step, as I mentioned earlier, we're having the regional meeting later in May, and we hope at that time that we will be able to work with countries to identify those gaps and challenges, put those into a work plan to see how best we will be able to work along with countries to actually address those gaps, advance with some of the areas as it relates to the laboratory services, the rapid tests that that Valerie just spoke about, and strengthening surveillance, which are some of the critical issues that we need to address in order to maintain the gains and to support countries in going forward to applying for the elimination of HIV, syphilis, and hepatitis B. We also look forward, Leandro and I would say more Leandro than myself, to actually support countries in identifying what would be the best approach in order to advance the countries and the Caribbean to the elimination of hepatitis B. So let's see which one of the countries we will be able to put forward first. So once again, thank you all very much for coming, and I look forward to working with you all as we work collaboratively to implement this project successfully, and more importantly, to ensure that we have a generation free of HIV, STI, syphilis, and hepatitis B in the Caribbean. A pleasant good day to all. Thank you for joining.
Thank you, and bye to everyone. Bye-bye.
Bye.
Bye.